I just want to say that it's quite an honor to be up here with such an amazing, dedicated, sort of caring group of individuals that feel really passionate about the work that they do. Previous speakers have commented on the importance of doing the right thing, and also have commented on the ethical challenges that they face in carrying that out. And so I want to do sort of similar to my radiation oncology colleague and get a show of hands. Who's heard the term moral distress before? Okay, so for some of you, hopefully this will be a review and also some strategies to combat moral distress within your own institution. So we've all seen the headlines, and I think many of our own institutions have implemented strategies dedicated to reducing burnout and achieving moral resiliency. And what I'd like to offer you today is a different understanding of burnout, one that situates the ideas of moral distress, moral community, and the ethical climate as central to the conversation around moral injury and burnout, which then I hope will allow us to discuss some potential strategies for both identifying and addressing moral distress in your own setting. So I have no disclosures except that I am a clinician and a clinical ethicist. So I would like to start by grounding us in two possible cases. So AJ is a 13-year-old male with recurrent osteosarcoma, admitted for chemotherapy, which confers a risk for infertility. His parents believe that he might refuse treatment altogether if he learns that his fertility is potentially impacted, and they've asked their son's primary oncologist not to tell him about this risk. AJ's bedside nurse, however, maybe has gone through echo training, and notices that the typical referral to a fertility specialist and semen collection have not been placed. And so he pages the resident to ask her to place the forgotten orders. So I ask you just to sit with the question about who in this scenario might experience moral distress. Case number 2, you return from an amazing Oncofertility conference convicted that a fertility navigator will allow equitable access to fertility-related care for all of your patients. Your department chair, however, refuses to budget for this position. Sound familiar? Your department, or you know that many patients and families in your own institution are not receiving adequate fertility counseling, but you feel helpless to make a change. So is this moral distress? Well, in order to identify the situations that give rise to moral distress, we have to have a working definition. But that's actually a little bit challenging since this is a relatively new term, first coined in the 90s and only applied to nursing literature. Since then, it's gained sort of broader audience and has been applied to all healthcare professionals. And I think these competing definitions within the literature really do highlight two key components. First, that we are feeling complicit in moral wrongdoing associated not with personal values, but with professional values, and also the lack of a voice or an ability to make changes. And so this helps us distinguish moral distress from other entities, such as when a provider is asked to participate in something that they are personally opposed to, like performing abortions, for instance. It's also not the same as having identified competing ethical claims with compelling arguments on either side where there's uncertainty about the ethically appropriate course of action. Neither is moral distress simply the feelings of sadness, anger, that may result from seeing families and patients struggle with a new cancer diagnosis. It's also not the feelings of helplessness or hopelessness that are a part of that constant exposure to other people's trauma, which might occur in secondary traumatic stress and compassion fatigue. Excuse me, let's see if I can go back. These are important factors, and I believe they are all potentially interrelated, but they are certainly distinct from moral distress. And maybe more importantly, moral distress is not experienced by all members of a healthcare team the same way, especially if those developing treatment plans and weighing treatment options are not the same as those carrying them out on a day-to-day basis. And so these different experiences of moral distress remind us that we all have different roles to play within a moral community and that there are different root causes of moral distress that impact us differently depending upon our own professional values. And so while the idea of a moral community existed long before there were healthcare organizations, it seems particularly well suited to describe the circumstances that we find ourselves in as teams of physicians, nurses, pharmacists, psychologists, genetic counselors, administrators, and researchers working within larger systems. Our larger systems have mission statements and a common purpose. We're also shaped by the ethical climate in which we practice, which is a combination of both our explicit and our implicit values. And these can either work to foster an environment that perpetuates or eliminates moral distress for healthcare professionals. So the root causes listed here have been broken down into patient, family, and unit and system causes that healthcare professionals might experience differently as a larger part of a community. So there's not a great theory-driven working model of moral distress in the literature, so this is just a visual learner myself's attempt to make this more digestible, and it's busy, but let's walk through it slowly. So as I've described, our membership within a moral community, like a large academic health system, involves a certain commitment to shared ideals and values of quality care, stewardship, education, research, and each of our professions also have guidance about our ethical code and our responsibilities. But each of us also retains the ability to act autonomously as a moral agent. And then we are exposed and impacted by patient, unit, and systems level factors that are unique to our own practice environment. And these are just some of the example factors that may impact our attention to act. And if it negatively impacts that intention, causing a failure to act in accordance with our professional identity and integrity, this can result in moral distress. And if it occurs repeatedly, this can negatively impact both the community, the individual, and the ethical climate, such that moral residue, the idea that moral distress that's unrecognized, builds upon itself in a crescendo-like effect, which heightens an individual's response to the next potentially morally distressing episode. And so if we think through those cases I presented at the beginning, I think we could easily situate the bedside nurse and the resident within this model as not owners of the decision and maybe not a complete understanding of the decision that the primary oncologist made. But I would argue that the primary oncologist could also be experiencing moral distress if they feel constrained by the family's request for specific accommodations related to their own beliefs. In case 2, again, our fertility champion has the intent to act morally and meet the standard of care regarding fertility counseling, but in this case, it's more systems level factors that may be at the heart of moral distress. And so the consequences of moral distress I alluded to earlier are significant. And while these headlines are meant just to capture your attention, the data is out there that there's a relationship between the experience of moral distress and job dissatisfaction, burnout, turnover, leading to loss of revenue for large healthcare systems, which of course impacts our ability to function as teams within that system and the quality of care that we're able to provide. And I would argue that ultimately what this does is impacts the ethical climate in which we experience our day-to-day jobs. But if that was the end of the story, it would be a bleak presentation indeed. So what I'd like to share with you next is the other pathway on this really busy slide that allows individuals to feel empowered and to act in accordance with those professional values which is ultimately associated with a sense of mattering, a sense of purpose, and resiliency, and positively impacts not only the individual, but the organization and the ethical climate. So assuming that the patient, unit, and system level factors are mostly universal, what we want to know is how do we limit their impact to reduce moral distress? And so the first idea would be that we need to identify and recognize moral distress as an entity. The presence of moral distress, the potential for root causes to exist within our healthcare systems, as well as the ethical climate of our systems can all be measured as a starting point. And so I'd like to highlight a few of the tools that are available out there. The first being the moral distress thermometer, which simply defines moral distress and then asks participants to circle the corresponding number that corresponds to their experience of moral distress within the last week. And this has not yet been done or described in Fertility Navigator, so a quick project that would meaningfully contribute to the literature on moral distress if anyone's interested. But if you'd like a more nuanced understanding of moral distress, either within your own care environment or within your own profession, the measure of moral distress for healthcare professionals represents a really recent and really robust revision of the moral distress scale, which was out there previously. It incorporated all of the data from the moral distress scale, as well as a robust review of the literature to identify 27 items, to alter the language so that it was applicable to all healthcare providers, not just nurses. And it looks at both the presence of moral distress as well as the intensity of moral distress and hypothesized root causes. Importantly, it also leaves blanks at the bottom for emerging root causes or root causes that might be unique to one's own environment. This has been tested successfully in different levels of care, so in acute settings, intensive care settings, as well as long-term care settings, and it's been tested and found to be valid in both pediatric and adult settings as well. Additionally, one could measure their ethical climate. Ethical climate has been shown to have an inverse relationship with moral distress in the literature, meaning that the worse your ethical climate, the higher your level of distress within your institution. And while you can see that some of these items, I've only chosen a few of the 26 items to highlight up there, some of them overlap with what we now understand to be root causes of moral distress. It also provides a broader picture of how one experiences the climate at one's own job, asking specifically about leadership and hospital policies. So once we can recognize and measure moral distress, of course we'd like to reduce and avoid all of those negative headlines. Unfortunately, this area of literature is not yet very well developed. So we have some studies looking at the effects of interventions related to moral distress, but I've included both those with and without data because it's a relatively new field. I've also sort of separated them based on whether their focus seems to be primarily at the individual, the unit, or the system level. So ethics education or moral empowerment or moral distress workshops can and often are done in a group setting, but the focus remains on building resiliency within the individual. The American Association of Critical Care Nurses has adopted this approach with their 4 A's to rise above moral distress, which is pictured here, asking the individual to ask questions of themselves, affirm a readiness to act, assess the environment and how they might go about that action, and then to actually act. But these individual-focused approaches, they share key components around providing education, providing resources for self-care and wellness and resiliency, but they've struggled really to demonstrate a meaningful or a sustained reduction in moral distress. And at best, it feels a little bit like a drop in the bucket, right? And at worst, it feels a little bit like victim shaming. So I'm certainly not opposed to empowering or educating individuals, but I would suggest that interventions at each level, the individual, the unit, and the system, are probably required to reduce moral change or moral distress and meaningful change. So at the unit level, the PEACE rounds, or Pediatric Ethics and Communication Excellence rounds, was piloted at Riley Children's Hospital by Dr. Lucia Voschel, who's a nurse ethicist. And this was an attempt to facilitate better communication among team members, specifically around both patient root causes of moral distress, such as requests for potentially inappropriate treatment, as well as including the voices of all team members. You note there that there's specifically spaces for 2 intensivists to comment, as well as a nurse on the team. So this allows team members to feel heard and actually for those things to be documented. You can see that it had no impact on moral distress in the study that they did, but did actually reduce length of stay, which was a secondary aim of this project. Another initiative out of Indiana University is the unit-based ethics conversation, which is a regularly scheduled protected time for teams to come together in settings usually at the highest risk of moral distress, so our intensive care units most typically. And while they did not measure moral distress, they did note that attendees at these unit-based ethics conversations felt both better able to address ethical issues and to manage challenging situations. The one dissatisfier being that people left the discussions feeling as though there was no resolution to many of their cases. Anecdotally, similarly, when people have these conversations, moral distress can increase. This is unpublished data because who wants to see that? But in part because you have these conversations which brings up the moral distress, and if there's no avenue forward, then people have a higher experience of moral distress immediately after these conversations. So another approach that focuses on that type of similar conversation, but takes it a step further with the intent to impact the system, is the moral distress consultation service, which has actually been implemented at my own institution. And it's often requested by unit leadership after a particularly difficult situation or a series of really challenging cases. Occasionally, it's an ethics consultant member who identifies moral distress as a component of a case that they're involved with and suggests a moral distress consult. And this consists of approximately an hour-long session that's a facilitated conversation, but it has 2 end products. The first being an action plan, and this is regardless of whether or not the patient is still in the hospital, because it has a lot less to do with that specific scenario and more to do with how the unit functions. And so often those can be things like requesting additional staff or proposing educational situations or opportunities for specific patient populations, such as sickle cell and pain crises, or oncology patients and their fertility needs. And the second product is a report of fully anonymous information to hospital leadership, which hopefully results in changes for the better in terms of how we support our staff, or in some circumstances has actually resulted in removing toxic providers that was a toxic provider whose behavior was negatively impacting the ethical climate. So an example of a true systems level change that didn't necessarily have the goal of targeting moral distress, but more maybe the ethical climate, is the VA's approach to integrated ethics. I don't know if there's anyone from the VA here, but this has been widely sort of publicized as a new novel way of approaching ethics as we approach other items, right? So that there's a quality, there's a measure of quality that we could do when we're having challenging situations. And so they've taken a quality improvement approach to ethics scenarios. And so, for example, if they identified that fertility conversations, which they understood as an ethical imperative, were only happening for a certain percentage of their patients, they would identify a team to study that and identify an evidence-based approach or strategy for increasing the number of participants or patients who are having fertility conversations until they had reached an agreed upon acceptable percentage of patients receiving fertility counseling. Another systems level approach is to use your health system's policies to address root causes. And so I've included two examples, again, from my own institution, where we've addressed sort of patients requesting inappropriate interventions. So this one is the example of our code status policy, which you can see specifically identifies team members' professional integrity as important to the institution. It also reinforces the idea that the code status should harmonize with realistic goals of care. And this really grew out of a widespread moral distress around bedside staff having to run codes on dying patients or patients with a low likelihood of ever surviving to discharge. Similarly, our hospital policy on medically and ethically inappropriate treatment not required was a direct result of recognizing moral distress at the end of life for our caregivers, as well as our caregivers having moral distress around the withholding of pain medication at the request of family members. And so I don't have data on how this has impacted moral distress within our own institution, but I do have the sense that by targeting policies and systems-wide changes, we're able to make a larger change more quickly. So each of these interventions really does target the ethical climate of the institution by providing education or open dialogue or accountability between the team members, thereby promoting moral agency and reducing moral distress. So if you've ever experienced moral distress, or if you never had a name for what you are experiencing, I hope this has helped to provide you with some clarity around what moral distress is so that we can begin to recognize it, to call it to attention for our leadership and our unit staff, and ultimately work together to find ways of reducing moral distress for ourselves and for others. Thank you.